Hey, Dr. Woodus here. I'm an OB-GYN speaker, author, podcaster, and I thought I'd try something new, which is to jump on while I'm in clinic, in between patients, and just share a little bit about my day. So on Wednesdays, today's Wednesday, on Wednesday, I set aside time, I block out time in my schedule to do surgeries and procedures. And so one of the things I just had the opportunity to do is place a Mirena IUD. So I thought I'd jump on and chat about it. Now, Mirena is a type of contraceptive, and it is by far, hands down, the favorite birth control method among all OB-GYNs. Like, if you ask any OB-GYN anywhere, I guarantee you 100% hands down what their favorite birth control method was. It would be the Mirena IUD. This little graphic here, model, shows you what the Mirena IUD looks like. It's a T-shaped device. IUD stands for intrauterine device, so it literally sits inside the uterus like you see here. So this is the uterus, this is the cervix, the mouth or the opening to the uterus. That's the part that dilates when we have babies. This is the vagina, the muscular tube where we place tampons and have sex. The fallopian tubes are coming off on each side here, and then the ovaries are here. So it's a T-shaped device that sits in the body of the uterus and provides very effective birth control. Mirenas are considered semi-permanent, which means that it is 99.99999% effective at preventing pregnancy. It doesn't get much better than that. And it is also FDA indicated for the treatment of heavy bleeding. So for menorrhagia, which is the medical term for heavy bleeding. Why? Because it significantly decreases the amount of blood loss with your cycle. So it's a very effective treatment for that purpose. It also helps to really significantly reduce or eliminate any symptoms you might have with your menstrual cycle. So that could be nausea, vomiting, stomach upset, severe cramping, all of those things we generally see improve significantly with Mirena. When I say significant, what you have to understand is that the Mirena is progesterone only. Progesterone is one of the two hormones that our body normally makes to control our cycle. Progesterone is responsible for the second half of our cycle, and what it does is it cleans and purges and flushes all of this tissue out of the uterus. So this lining, this inside lining of the uterus, is called your endometrium. Endo, think indoors. Metrium refers to the uterus. So when it is here, it's going to clean and purge and flush this tissue out of the uterus and then not allow it to grow back. So you do have to have right expectations when you are being counseled about the Mirena. You have to understand that in most cases, in the first 1 to 3 months, you will see more frequent bleeding that is not predictable, meaning you cannot look at a calendar and anticipate when your cycle is coming. And it could be every single day of your life. I'm going to put this down. But if you just yet hold on, stay the course, what you will see is 80% less bleeding when it works well at 3 months of use, greater than 90% less bleeding at 6 months of use, and the vast majority of women will stop having anything they would consider a cycle at all at a year going forward. Like if they do have bleeding, we're talking light panty liner type spotting that is months and months in between, like completely insignificant. So that is the beauty of Mirena. It's also low maintenance, so you get to put it in and forget about it. As in, you don't have to remember to take a pill every day. You don't have to change a patch every week. You don't have to change a vaginal ring every month. It is a beautiful thing. I love it for college students getting ready to go away for college. I love it for busy moms. I love it for anybody who is an appropriate candidate. So let's talk about how Mirena is inserted. So we set you up like we're doing a routine pelvic exam, put your feet in footrests. We clean the cervix with surgical soap, and then we use this long skinny tube, make sure you guys can see this, to measure the cavity length to make sure that the size of the uterus is appropriate. So Mirena is a one-size-fits-all device. As you can see here, this is a model of the Mirena. So if the uterus is too big, you can imagine how that could fall out. And if the uterus is too small, you can imagine how it might not be a good fit. So we measure the cavity to make sure that it's appropriate. And then, I'll show you this model here. You can see this. So we literally insert Mirena like so. We activate the little arms of the T, push it up to the top of the uterus, and leave it all the way inside, like you can see there. So it's as simple as that. And then we just trim the strings. This model does a better job showing you the strings. These are like threads in your clothing. You can't really feel them unless you put your fingers in the vagina to feel and make sure it's in the right place. And we do encourage you to do that periodically to make sure that everything is okay. But partners don't really complain about being irritated by the strings during intercourse. I literally experience that less than once a year. When I do experience that, a lot of times it's just a matter of trimming the strings to make it more comfortable. But yeah, it's a beautiful thing. Mirena is indicated for use for up to 8 years if we're using it for pregnancy prevention only. If we're using it for the control of heavy bleeding, then it's indicated for use up to 5 years. Yeah. So because we are going inside the body, as you can see here, it's an invasive form of birth control. So there are some more risks associated with that. What are those risks? Anytime we go inside the body, pain, infection, bleeding are always at the top of my list. Just like if you cut yourself, those would be the things that I would be worried about. It going through the muscle layer of the uterus is a possibility. It falling out, just like we talked about, is a possibility as well. Now, this happens very, very rarely, like less than 1% of the time. What I do in my clinic is I bring patients back at 1 month to do an ultrasound to make sure it's in the right place and make sure that they are not having any problems with it. If it does go through the muscle layer of the uterus, sometimes surgery in the hospital is required to see where it is and to remove it. Sometimes imaging needs to be done, like a pelvic x-ray or ultrasound, to locate where that IUD is, and then it is removed. It could also affect anything in the surrounding area. So remember, surrounding our uterus is bowel. The bladder is attached to the front lower part of the uterus, nerves, blood vessels, tubes, ovaries on either side. So those things being in close proximity puts it at risk for injury. But again, that happens very, very rarely. Like we said, 99.999% effective at preventing pregnancy, meaning that it is not 100%. So if a pregnancy occurs, which is highly unlikely, early evaluation needs to be done to make sure that that pregnancy is in the right place in the cavity of the uterus and to make sure that everything looks good. If it's confirmed that the pregnancy is in the right place, the IUD needs to be removed. And we know that if the IUD is removed with a pregnancy, that does slightly increase your risk for miscarriage. If it's unable to be removed, so for example, if the strings aren't visible because the pregnancy is too far along, for example, then the IUD would just remain. But we understand that that can increase your risk potentially for pregnancy complications like infection. So that is the Mirena IUD. The removal process is usually very smooth as well. In fact, my procedure this morning was a replacement. So the patient already had an IUD. She loves it so much that we replaced it because it had expired with a new IUD. So the removal procedure typically is just the opposite. So we put the speculum in the vagina, again, clean the cervix with surgical soap. As long as we can see the strings, it's just a matter of grasping the strings with an instrument like a forceps and pulling it out. We show the IUD to the patient once it's removed so that they can visually confirm that it is indeed intact. Now, what does replacement look like if we can't see the strings? Way more involved, potentially. So sometimes we'll use an IUD hook, which is really barbaric, and I do not like to use it. But it literally, like, think crochet hook, okay? Like crochet hook, literally. So it is a literal hook that you put in the uterus, and you fish around until you hook the crossbars of the T, and you pull it down. As you can imagine, that feels exactly the way that it sounds. So typically is a very uncomfortable procedure. Alternatively, what I like to do is what's called office hysteroscopy. Hysteroscopy, oscopy means looking with a scope. So I literally place a tiny camera in my clinic inside the uterus where I can see directly in the cavity and identify the IUD, and I just take graspers and pull it out. I think that that is way more humane. It's a quick procedure. It's way less uncomfortable for the patient. So that's definitely the way I prefer to do it if I cannot see the strings. Let's see. Lots of patients are scared of IUDs because of the pain that's perceived with the insertion and the removal process. There are a lot of things that I do in clinic that will help to decrease the pain and the discomfort that patients experience with the insertion and the removal of the IUD. Number one, I like to insert it on the lighter days of your cycle, which, think about it, makes sense. I know that patients don't always feel comfortable being examined, having a pelvic exam, a pap smear during your menstrual cycle because they're self-conscious about the menstrual blood. But remember, as OB-GYNs, we do this all day, every day. We are not fazed by menstrual blood. But if you think about it, the advantage to the patient is if you are already on your cycle, your cervix is already, I'm dropping everything. Your cervix is already open a little bit to allow the blood and tissue to come out. So it's easier to get this IUD in. And I don't have to fight with and struggle with your cervix to get it to open for me to get that IUD to go in. So that's the first thing. We place it on the lighter days of your cycle. I also have patients pre-medicate with anti-inflammatory medicines. These are Motrin, Aleve, naproxen, ibuprofen. My go-to is 800 milligrams of ibuprofen 1 hour before the procedure. I also will sometimes give patients a medicine that will help to soften and open up that cervix. Think low dose of what we would use to prep you for labor that will also help to make that cervix easier to get into and that IUD to be placed. We can also, in the right patient, use numbing medicine. So we can inject the cervix with numbing medicine to make it easier as well. Now, I do try to let patients know that the numbing medicine will help make it more comfortable if there's a need to place an instrument on the cervix in order to aid with the insertion of the IUD, but it really doesn't do anything for cramping. And it really is cramping that patients experience that I would say they complain the most about with the IUD insertions and removals. And the reason that the numbing medicine for the cervix does not work as well is because it is a different set of nerves that supply the uterus versus what supplies the cervix. So even if I'm able to numb the cervix, the cramping comes from the uterus. So it doesn't really help with the cramping of the uterus, but it does help because sometimes it is necessary to place an instrument on the cervix in order to straighten out the uterus and make it a straight shot for that IUD to go directly into the cavity. So that does help some patients. Alternatively, we have Pronox in our clinic, which is like laughing gas in the dentist's office. It's a completely patient controlled 50-50 oxygen nitrous oxide mix that you just breathe in and out, slow, easy breaths, kind of makes you feel high. But very safe to use. There are very few patients who have medical problems or other indications where it cannot be used. It does not linger or last in your system, so it's out of your system within 15 minutes, does not impair you so that you can still drive yourself home. And interestingly, while we're on the subject of pain medicine, I recently came across some new research that shows that a vibrator, like placing a vibrator on the abdomen near the belly button, those sensations also impact the neurologic pathways so that it helps you manage pain better as well. Now, that's not something I've tried in my clinic just yet, but it might be something I need to try out and just kind of do my own little patient-led experiment and see what patients think in terms of pain control. But in general, I would not expect more than cramping or spotting after the IUD insertion or removal. And your provider, your physician should go over warning signs in terms of what's too much, when to be worried, when to look out. I have not seen any significant adverse side effects with the insertion or the removal, but in general, if you have severe pain, 10 out of 10, what you're taking is not helping it, that's too much. You need to call your provider or go to the ER. If you have heavy bleeding where you're soaking, flooding your pad, you have to change it every hour because it's saturated. And I mean, top to bottom, side to side, that goes on for more than 2 hours. That's too much. You need to call your OB-GYN. If you have nausea, vomiting where you're not keeping anything down, even liquids are coming back up, and this is going on for more than 4 to 6 hours, you need to call your OB-GYN. And if you have, fever, temperature of 100.4 or more, you definitely need to call your OB-GYN. Again, I've not seen any of those things, and I would not anticipate any of those things. All right, so that's the Mirena IUD. The Mirena is a great postpartum birth control. It can actually be placed in the immediate postpartum period. That's not something I traditionally do in my practice, but that is something that has been practiced in other locations. A lot of times you'll think about doing an immediate postpartum placement for women who may get lost to follow-up in the postpartum period, may not have access, maybe they might lose their insurance in that immediate postpartum period, and you want to make sure that they are covered and they want to make sure that they have reliable birth control. But typically when it comes to postpartum birth control, I usually like to wait until about 8 weeks after delivery to place the IUD because you do want to give sufficient time for the uterus to go back from pre-pregnancy size or pregnancy size to pre-pregnancy size. It also allows the muscle layer of the uterus, this portion of the uterus, to firm up because this layer is really, really soft in that immediate postpartum period. And the softer this muscle layer is, the more likely that IUD can perforate or go through that muscle layer of the uterus. So that is the Mirena IUD. There are other types of progesterone-only IUDs. An example of one is here, Kyleena. You can see that Kyleena. Kyleena is like the little sister to the Mirena. And I usually use Kyleena's, the smaller IUD, in my young ladies. So like my teenagers getting ready to go off to college who want long-term low maintenance birth control, or maybe women who've never had any babies because their uterus is going to be smaller. And so there is no like limits to the size of the uterus that you can put the Kyleena in. Whereas for the Mirena, it's a little bit larger and lasts just a little bit longer. So that's the Mirena IUD. Let me know if you enjoyed this. These just like pop in on the fly, in between clinic patients, informational sessions, and I will continue them. I think that I'm enjoying doing this, so maybe we'll try to make this a regular, consistent thing, maybe even daily, since I'm in clinic all day and oftentimes find myself waiting on folks. So we'll check it out. We'll try it out. We'll see what happens. All right. See you guys later.